Hello, and welcome to the opening session of CogX. It is fantastic to be here with you all, and amazing to see so many people in person after 2 years where CogX was only online. So it's fabulous to be here. We have a very appropriate first panel for you here, which is about the mental health crisis. After a very difficult 2 years for so many people, we're going to be talking about mental health, but also this tantalizing possibility that psychedelics are going to become the next frontier in curing this mental health crisis, and the amazing research that's going on at the moment. Here to discuss this, we have some real titans of this world, who I'm going to let introduce themselves very briefly. Christian, could you give us the 30 seconds?
Ladies first, but like, okay. Good morning, everybody. My name is Christian Angermayer. I'm running my investment firm, Apeiron Investment Group, and I'm the founder of Atai, which is one of the larger companies in that sort of mental health / psychedelic space, because we also do other therapeutics, which are not psychedelics, but psychedelics are sort of my big passion, I would say. And we also have a stake to almost include or introduce Katja in Compass Pathways as well. So we're a little bit related in a very nice way.
Mm-hmm. Catherine?
Hi, everyone. My name is Catherine Bird. I'm a clinical trials manager at King's College London, working with a research group called the Psychedelic Trials Group, where we do clinical trials investigating the use of psychedelics for mental health treatment. And we've been working with Compass for sort of 4 years now.
Yeah.
They fund some of our studies, and we've been investigating their product, COMP360 psilocybin.
Hi, everyone. My name is Ekaterina Malievskaia. I'm a co-founder and chief innovation officer of Compass Pathways. We are a mental health care company, not a psychedelic company. Our mission is to accelerate patients' access to evidence-based innovation in mental health. However, our first program is developing psilocybin, a proprietary formulation of psilocybin, COMP360, for treatment-resistant depression. We just completed a phase 2b studies, and we're also researching the use of psilocybin for other indications of significant unmet need.
Fantastic. So can we just step back a moment and set the scene about the mental health crisis at the moment? I was reading an article in the New York Times just the other day with some amazing statistics. It was about young people, but I think it's prevalent to what's going on in the world. It was talking about 60% rise in self-harm rate in America. It was talking about a 6% rise in suicide rates in America. The Surgeon General was calling this a devastating crisis. Obviously, COVID has accelerated all of this, but like there's this feeling in the world that the mental health crisis is getting so much worse. Christian, can you just tell us what is happening? Can you lay this out for us and set the scene for the psychedelic renaissance? But what's happening to us, Christian?
Well, where do we start? Like in numbers, meaning there's always this famous number floating around that sort of the official WHO number is 1 billion people globally have one or more mental health issues, from depression, anxiety, addiction, body dysmorphia, whatever. Yeah, which is already, so if we would stop here, 1 billion makes it the largest sort of group of issues, of illnesses, and sort of the number one problem of the healthcare system. By the way, also because, meaning obviously 1 billion people is 1 billion people too much or too many. But like there is also like, especially mental health has also a ripple effect, on the people around, people who are depressed, on families, like on workplaces. So it's sort of practically, you can say, if, and then I come to the way higher number, but if already 1 billion people acknowledged have a mental health issue, directly or indirectly, because you know somebody who has it and are affected, sort of everybody is sort of in touch with that problem. Having said that, unfortunately, that 1 billion people number is grossly underestimated for mainly 3 reasons. The one is like all these global numbers always take years to be compiled. So this 1 billion number is still a pre-COVID number. And actually on a country level, you see the sort of numbers coming in now for actually 2020, so still delayed, but sort of the first numbers on in Germany, in the UK, are coming in from an in-COVID level, and they are all going up, unfortunately, double-digit, because obviously sort of COVID made mental health worse because it was playing into many drivers of mental health, loneliness, whatever, which sort of is fueling mental health issues. So COVID as an imminent problem will dramatically, and we're going to see that more and more, increase that number. Then second, although we are sitting here and talking about it, overall mental health issues, especially when patients sort of coming forward, are still stigmatized. It's getting better, yeah, because more and more people publicly speak about their mental health and how important it is also to be honest and seek help, whatever, but it's still stigmatized. That means not everybody who deserves help, needs help, yeah, is also seeking help, going to a therapist, going to a doctor. And in this 1 billion people number, that's just the one who come forward with it. So with luckily growing destigmatization, unfortunately, automatically, we're going to see the numbers rise because more people sort of are outing themselves. And then the third, maybe the more long-term or the umbrella around that, that's sort of a little bit my personal belief. Like there is not a lot of research actually. Why do people get actually mental health issues? We look at it when they're there. Yeah, is that the world we're building, and actually, by the way, the world we sort of celebrating at this festival, technological innovation, disruption, a world which is changing, yeah, all the time, I believe is not good for our brain, who's desperately seeking stability, planability, continuity. So practically everything we seen, and COVID practically is just one example which boosted that. We're going to see more and more sort of a rise, a natural growth, almost to say, yeah, in that. And so in that all together is the perfect storm. So I bet we're sitting here in 3, 4, 5 years, yeah, and unfortunately the number will be 2 billion or more.
Thanks, Christian. And Katja, my understanding is that against this backdrop of a worsening mental health crisis, there's been surprisingly little innovation in mental health. The kind of pharmaceutical industry has been very good at giving us many different types of Viagra, but the types of mental health medication hasn't really changed that much in the last 30 years. Can you give us a flavor of like that lack of innovation, and I suppose like what's now like emerging and coming into this?
Yeah, that's absolutely true. It hasn't been any meaningful innovation in mental health space for decades, maybe 50, 60 years since maybe the introduction of neuroleptics or antidepressants prior to that. And with any other industry, in terms of public health, what you see is, for example, when it comes to cardiovascular health, if you see the increased spending in industry, increased spending on R&D and drug development, then the prevalence of disease, that is the number of cases in the population, goes down. But in case of mental health, there are more and more drugs being developed, more and more spending on mental health research in the industry. But the rise in mental health problems actually outpaces this development. So what it tells you is that, are we looking at the right targets? Number one. Number two is that the mental health problems are incredibly heterogeneous. And it could be, personal history, personal narrative, the way people sort of interpret their life events. It could be neurobiological. But I think the general sense increasingly with advancement of science that it's really multifaceted, there are different reasons why people experience depression. It's not a uniform diagnosis like in any medical specialty. It's probably a manifestation of many different things combined in various ways.
So there is innovation, but just the paradigm for this innovation.
The paradigm is but I think we're getting there, right? So I think we're going towards the more precision, predictive, preventative models, but the science is trying to catch up on it. I think psychedelics offer one of the most interesting solutions. Again, I want to preface it with that it doesn't work for everyone. Nothing works for everyone. And but the way psychedelics, sort of the psychedelic experience works is that it's a combination of psychopharmacological events, effects of the drug, that is changes in the brain chemistry and receptors, as well as patients are able to get a sense of agency over their own experience. It changes their relationship with symptoms, with their personal narrative. It's empowering in a way like no other treatment. And so all these bits and pieces need to be researched in a kind of a deep and responsible way, and we're just starting doing it.
Catherine, can you give us a sense? I think a lot of people in the audience will be really excited to get into, like, what is it about psychedelics that is a different paradigm, and why does it work? Could you maybe start by just telling us what happens in your brain when you have a mental health problem? And that's, forgive me if that's ridiculously broad question designed to embarrass you. No, like, can you give us a sense of very generally what happens?
Yeah, of course.
And then, like, how the psychedelics, combat that, and what's really going on?
Exactly. I think what Katya just said about mental health disorders being heterogeneous is a very important sort of place to start. So when we say heterogeneous, we mean that they can present, like each case can present in very different ways. So two people with depression may have a slightly different symptom profile, slightly different cause. Is it a genetic link? Is it a personal history issue? So when you think about a biological model for what's happening in the brain when people have depression, no one's really been able to come up with one cohesive model that we say this is what happens, and it's because everyone's experience is different. With that said, I will sort of try and explain, what might be happening in the brain when people have a mental health condition like depression. It's really helpful when you think about the brain to think about it in sort of different levels. So you can think about the brain at sort of the cellular level, where chemical communications are happening. So these are neurotransmitter chemicals, which sort of is how neurons talk to each other. And you hear things like serotonin, dopamine, glutamate. Those are examples of neurotransmitters. Then if you zoom out a little bit, you can think about how the brain works on a regional or systemic level. So how do circuits, how do different regions talk to each other? So they're using the chemical messengers, but then there's sort of these different regions are interacting to affect how we think, how we behave, how we interact with our environment. So if you zoom out a little bit more, then you think about, the brain's not an island. Everything that's happening in there, down from that level up to the systems level, affects how we interact with our body, with our environment, within relationships. So if you sort of think about that, all these different sort of circuits happening in the brain, and they affect how we regulate our mood, affect how we sort of perceive ourselves, different attentional things like cognitive processes. And so when someone, say, is exposed to chronic stress, like when people have depression or experience sort of stressful life events, these connections can become less sort of efficient, and things become a bit more noisy, and as a result, maladaptive or unhelpful behaviors can arise. So, for example, in depression, people tend to not be able to focus on more positive events, and sort of their attention shifts towards more negative things. Or you can ruminate. That's one of the symptoms of depression, where you sort of overthink certain things, and this is sort of just one of the few symptoms that people can have, and I'm not going to go through the entire profile. And so, one of the theories about this is that it's called the monoaminergic deficiency hypothesis, and it's a sort of old school idea of that when we're sort of lacking in certain neurotransmitters, then we have depression. But obviously that's sort of quite basic, and we're sort of now trying to think about treatments on how the chemical systems in the brain then affect how we behave, and how can we sort of work with those psychological processes as well. So SSRIs, or antidepressants, were sort of developed on that sort of deficiency hypothesis. We don't have enough serotonin, so we give some more, and you get better. But that doesn't work for everyone. It does work for some people. But with psychedelics, they sort of interact with these neurotransmitter systems, but then they sort of produce these very unique subjective experiences, so psychological experiences that can be related to feeling connections with oneself, sort of oceanic boundlessness, and these sort of very unique subjective experiences, which then may or may not translate into betterment of symptoms or improved mood. So I won't go into too much more detail, but maybe we can talk about it more.
But the basic point is that it's more of a systems. It's more of a like whole systems way of thinking about.
Sure. I mean that. Yeah. So I mean one of the everyone likes to talk about the default mode network, which is a network that is implicated in depression. So it's not really a task-based network. It's sort of how you refer to yourself, and sort of when you're not actively doing anything, sort of it's in self-cognition, sort of how you perceive things. And that can be abnormal in depression, so that functioning can be abnormal in depression. And there's some studies that show that psychedelics sort of disrupt that sort of rigidity that comes in the default mode network when people have depression. But again, that's just one of the theories that people have suggested. It's not necessarily, in my opinion, the way that psychedelics work, but it will contribute.
Yeah.
Yeah.
And where are we, for those in the audience who haven't been following this all quite so closely, Christian, maybe you could just give a little sense for everyone of where we are in the journey of the various different psychedelics. As in, like, what are people most likely to be prescribed in 2 years' time versus 5 years' time versus 10 years' time? Like, what's the progress look like?
Yeah. So quickly, meaning because you mentioned it, there are different psychedelics. Sort of. Here, Katja mentioned Compass is working with psilocybin, which is the sort of intellectual word for the colloquial magic mushrooms. So it's the active ingredient in magic mushrooms. Then there are more psychedelics like DMT, which people know from ayahuasca, for example, which is a ritualistic psychedelic drink in South America mainly. You have ibogaine, which is actually coming from a root in Africa. So a lot of them, of these sort of core, or let's say first generation, how we call it, psychedelics, were actually used in the sort of the natural version, the plant-based version, in many shamanistic rituals around the world. Then you have some where there's, I would say, not debatable is the wrong word, but like some like counted to psychedelics. So you have actually ketamine and MDMA. Yeah. So are they psychedelic, or are they wider psychedelic, because you don't really have this trippy experience which you have on the core psychedelic. So for sort of to have the broad picture, I would also include them. So long story short, the two sort of most advanced compounds in clinical trials is actually what Compass is doing, psilocybin. So Compass is hopefully entering this year in phase 3, which is in biotech terms sort of the last one before approval. And the same is actually MDMA, which is done by a non-profit called MAPS, which is also is already in phase 3. So very vaguely, Katja will say this is why I'm saying it, because companies in biotech I should not give timelines exactly, but I would say a normal industry experience is that you would say once a drug enters in phase 3, and provided that we expect that phase 3 is going to be successful, there could be the chance that the respective drug is sort of available then in, let's say, 2 to 3 year-ish, because then you also need to sort of roll it out, educate the doctors, which, by the way, just a side note here with psychedelics is an especially important topic, because all the companies, Compass, Atai, these core psychedelics where you have a trip, as just described, are not meant to be prescribed and you take it home. and then would do it alone. So, but you go to your doctor, so they bound to the hospital, to the clinic, you go to your therapist and do the trip with them, which is double important. A, because sort of in the moment you do the trip for various reasons, you need, like it's colloquially called a trip sitter, which would then be a therapist, but also it's not just the trip alone, there is a whole pre-work, like preparation and then integration, because as it was mentioned already, it can help you to create sort of a shift in how you, for example, look at yourself, look at the world, but in order to fortify sort of that positive change which a psychedelic trip might bring, you want to actually then work with a therapist in order to sort of make that trip, make the experience, strong and sort of included in or really change your behavior. So having said it, so the two most advanced psychedelics, again, if I say MDMA is a psychedelics, which some won't like, but in this world is psilocybin from Compass and MDMA. And then all the other ones I just mentioned, DMT, ibogaine, are following the years after. So I would say if everything goes positively well, there should be therapists able, I would say in 3 years, to work with the first psychedelic substances, and then more psychedelic substances to come over the next 5 to 7 years, or like say from 3 and then 5 years. So, but actually for biotech terms, you might say, Jesus, I don't want to wait that long. I want to do it tomorrow. But like in a biotech term, that's actually pretty quick.
And in terms of what what they're actually curing or helping, it's for psilocybin, magic mushrooms, it's depression. For MDMA, it's
PTSD.
PTSD. And then the other ones, can you give a flavor of the main, I don't know what the term is, like the main indicators?
So you actually always have a so-called lead indication. So that's what your sort of main trial is. And for psilocybin with Compass, it's treatment-resistant depression. However, and then actually you should let Katja speak about it, there is a variety of then additional trials you do, because sort of psychedelics, again, don't work for everything, but like have a broad application. And then you can actually say, like, in the nuances, the one psychedelic might work better for A and the other one for B. This is why, again, it is so important that a therapist is sort of administering it, because it will be the therapist who sort of looks at the patient. By the way, in the first instance, we'll say, is it psychedelics at all we should go, or should we go, because I said before, like, the mental health issues are sort of multifold, and also the reason why so it's not even that you can say, oh, depression is always stemming from this and PTSD from this. Actually, you have multiple sort of root causes which can lead to the same expression: depression, PTSD, anxiety, or whatsoever. And this is why I need a therapist first who makes I guess is such a random word, like who makes an assumption, where is this coming from? And then we'll say, okay, let's go this route, or let's try psychedelics. And then when the decision is let's try psychedelics, then again, it might be different psychedelics for different indications. Meaning a very strong example is that all psychedelics show actually great properties of anti-addiction, or to dissolve addiction. So I don't even know if Compass, I think, is also doing addiction studies, but so you can almost use any psychedelic to sort of soften or get rid of addiction. But the most or the strongest addiction known is opioid and heroin addiction. And there, for example, it's very clear that ibogaine, which more or less is solely we focus on, is one drug we develop on this anti-addictive property, but has the strongest sort of results there. So, for example, if somebody is opioid addict, you would always most likely go to ibogaine first, while if somebody just wants to get rid of smoking addiction, you might actually do it with psilocybin. Why psilocybin better in that case? Because ibogaine is a very, very strong psychedelic, which actually will most likely require not just a day visit to the therapist, but like a several-day clinic. So you do it rather for the stronger stuff. You wouldn't sort of shoot, I don't know if it's an English term, but with a cannon on on a bird, like, and say, okay, if it's just smoking, yeah, then let's go with psilocybin because that's just a 4-hour trip, yeah, with your therapist.
I might want to kind of add a little bit. So there are two paths really for psychedelics. One is recreational use, and if you are a well-integrated person curious about self-development, then that's probably the path. But what we're doing here is for people with serious mental illness. And what the studies increasingly show is that if you do have a diagnosable mental illness and severe mental illness like OCD, treatment-resistant depression, PTSD, anorexia, then probably these people should not go to mushroom retreats because things can go really, really wrong. And I think we need to be really honest. I think there's a lot of media attention to psychedelics, and every day there is an article about, healing properties of psychedelics, and, it's good for everything from bad marriage to world peace. But it's unfortunately people with serious mental illness could have adverse events, and then it will be very difficult to help them. And once we enter the path of clinical development, we follow the same path like any other drug. And it's a very, it's not sexy, it's very technically challenging, it's a highly technical climb, it's very expensive, and it's boring. And we just have to do a lot of tedious things to actually bring these treatments to patients, and we need to be absolutely sure how they work, who they work for, how to support these people, what to expect, and how to follow up. And this is really, really important. I can't overstate the importance of this kind of a sober and thoughtful approach to people with serious mental illness, because they've been suffering for decades. They were without any effective treatments for decades. And to, raise their hopes. And some people come to our trials and say, this is my last hope. I'm here to be cured. That's not the case. We're just starting. And the other thing about psychedelics is that I think it's not only an interesting therapeutic and clinical tool, it's also an interesting diagnostic and research tool. So it allows us to identify new therapeutic targets, new receptors, the way, receptors work, the way the, brain connectivity work. Catherine mentioned default mode network. That's basically the collection of your patterns, how you think about the world, how you plan. And default mode network gets downregulated, and it's thought to be one of the mechanisms that allows patients with psychedelic experience to look at their, conflicts, their narratives from a different vantage point, because they're unencumbered by their patterns. That allows us to identify new subjective mechanisms of change and improve talk therapy. You may not need the drug for that, but it will allow us to develop new approaches, post-denominational approaches to talk therapies. They're not CBTs, DBTs, IPTs. It's something new. So I think it's equally interesting research tool.
Can we talk a little bit about set and setting? You mentioned a kind of new paradigm for mental health, but there's also a new, almost kind of business paradigm for how you develop these drugs, because you can't just, as Christian and you mentioned, you don't just give people a bottle and tell them to go
Have
home and take one. It's a far more sort of rigorous and dynamic and kind of full-on process that you have to guide these people through. This is obviously partly a business audience. Kind of how, are there any precedents for that in the mental health world, and how does that how are you thinking about that now? I don't know if, Ashimi.
Yeah, I can. Well, you mentioned set and setting, which is a really important sort of.
Maybe you could just describe what that is.
So set and setting refers to sort of two things that interact with each other. Set is sort of the participant's mindset, their sort of understanding of where they are, what the treatment, in this case psychedelics, is, and this is the sort of emotional and psychological state that they bring to the facility when they're about to take part in a clinical trial. And the setting is sort of the physical setting. Psychedelics make you sort of more sensitive to your surroundings, and therefore it's important to pay attention to the rooms. We don't just stick people in a hospital room and give them psilocybin and say, there you go. This also refers to the relationships that they have with their therapist or their psychological support practitioner. So these factors all sort of work together to influence the psychedelic experience itself, which then may also indirectly influence the outcomes, be that more positive or negative. I think what Katya said earlier is really important, and I do really want to hone this point home about sort of the hype and the media that happens. It's a bit of a double-edged sword because obviously we all want the stigma to sort of be challenged, and therefore it's great that people are talking about how good psychedelics are and how helpful they are and how they can cure things and how they can reboot your brain. But when people come to us, participants who have suffered for 20 years with depression, and say, I can't wait for you to reboot my brain, we sort of have to work with that and say, hang on a second, that wouldn't be fair to the whole process that is involved, which is the hours of preparation with the therapist, the sort of openness to having a altered state of consciousness experience, and then the work that goes in after to integrate all of those things. So yeah, whilst I am grateful that the world is sort of looking to psychedelics, I do sort of heed caution and when you're sort of thinking about all these exciting ways of describing psychedelics.
But what are the challenges? I guess almost, you're doing these clinical trials, and I guess that feels like probably the most important thing is actually getting these drugs approved. But once that's done, what are the challenges of like rolling this out to 1 billion people? I mean, you're talking about these huge numbers, Christian, but you need to get these drugs to these people, and you can't get them just to pick it up in their local pharmacy.
We're gonna plug into an meaning there are therapists there, yeah, and yes, they're most likely too little. By the way, they're already too little now. Like it's like sort of, yeah. So at the margin, I think because a lot of time goes, from my point of view, at the moment in, for example, Katya mentioned talk therapy, which standalone doesn't yield a lot of at least a lot of improvement. So a lot of people actually barely stay sort of stable. Yeah. So the hope is a bit, but that's sort of really like on efficiency terms, that psychedelics actually will add a lot of improvement to the optionality what therapists can do. Yeah. So while sort of everybody's like, oh, then all these 1 billion people need a 4-hour therapist, like who's going to do that? I'm like, yeah, but these therapists are at the moment doing a lot of, it's not inefficient, but sort of suboptimal stuff because they don't have the right tools, yeah? So they're going to balance it out a little bit. But having said that, they're still too little therapists. Like, sort of in a little bit on the emotional side, my hope is that once psychedelics are gradually approved, we actually going to see the job description of a therapist as a more rewarding one, because I have actually talked to really a lot of therapists. Some of them actually do it underground because they're like, if I have a patient, and some of them, if they're old enough, actually have seen a time when some of these psychedelics were actually available, yeah, where the therapists are saying, hey, if I have a patient where I know this could be the way, and the patient is really, really in a bad status, I'm as a doctor almost obliged to do it, although at the moment it's illegal. Yeah, so in a positive way, I think it will add such a big, again, more and more psychedelics will come to market, yeah, like a tool set to therapists, so that hopefully the job description of, oh, I want to become a therapist, I can really help people now, becomes more desirable, and then we're going to hopefully have, yeah, more therapists, yeah. But yes, on the first day, yeah, obviously not all of these 1 billion people will have access to it, but unfortunately, that's already the case now. Not all of these 1 billion people have access to therapists and proper therapies now. Yeah, so gradually, I think it's going to improve.
I think they should.
I'm just going to turn to questions in a minute. So if people could think of some brilliant questions, But sorry, Katie.
I wanted to say that the number one challenge is to get these treatments reimbursed, to get these treatments integrated into the clinical care guidelines, and for them to be covered by national health systems in Europe, where health is a basic human right, and in the US to have conversation with a multiverse of payers and insurers to make sure that they see the value of these treatments, the value that is created for health system and for society. That's not a small task, and that's why we work with regulators and payers together, and we start very early to understand what evidence regulators will need to see in order to be able to reimburse these treatments. Because we can train therapists, we can select therapists. Christian is absolutely right. It's hugely rewarding for therapists to see such a dramatic change in the patient after one session. However, if it's not reimbursed, marginalized communities, underprivileged communities that would benefit from it the most will never get access. If you think about underground session right now, it's between $25,000 and $5,000 per session for 1 day of a session. Very, very few people can afford this. So our goal is to have it reimbursed and have it be acceptable treatment that can be adapted by health systems.
Any questions from the audience about the emerging field of psychedelics? Yes, the lady in white over there.
Lady in white.
Hi, my name is Elena. Fascinating talk today. My question is actually about microdosing and benefits of microdosing of psychedelics. So, can you hear me? Now it's better. So.
Microdosing.
Yes, thank you. Microdosing, and how soon are we going to see a substitute for a Friday beer in office with a microdosing with your co-workers, for example? And do you do any trials on adolescents? Thank you.
So, short answer to the second question is no, we don't do trials with adolescents. Various reasons, mainly at the moment because we are still in we sort of just finished phase 2 with psilocybin, and a lot of that is to do with finding out safety. And, you wouldn't just say, oh, it works for adults, let's give it to an adolescent. The adolescents' brains are still developing, and when you don't fully understand how a substance works in the brain, it would be irresponsible. With microdosing, is it ever going to replace a Friday beer? Definitely not in the UK. People like to go to the pub after work, but in terms of the scientific evidence around microdosing, it's very, very sparse. It's quite hard because we can't give people microdoses to take home and test it because it's still an illegal substance. So really, we don't know is the answer to do with microdosing, but there's obviously a wealth of anecdotal evidence around people saying that it sort of helps them with their sort of day-to-day functioning. But again, is that placebo? Is that sort of just an anecdote? We don't know at this point.
I think up to date, there has been 3 studies, 2 with psilocybin, 1 with LSD on microdosing, that I think only one of them was adequately controlled. It's in terms of evidence, there is no evidence that microdosing is beneficial. Another point here is that psilocybin and classic psychedelics bind to the receptor called 5-HT2B, which, if stimulated significantly and for a prolonged period of time, can lead to heart damage. And so there is not only there is no efficacy data on microdosing, and there's no physiologically plausible mechanism how people could benefit from psychedelics. There are also some safety concerns in terms of heart valve damage. I don't want to be a wet blanket, but on microdosing.
Thank you. Yes, sir, at the back.
Hi there. Hi. My name is Emilios Lemoniatis. I'm a child psychiatrist and I work in the NHS in London. In my personal capacity, I've heard that people are using these drugs in a kind of underground black market way in London. People claiming to be therapists, maybe they're trained or not trained. What is the panel doing to make people aware of the risks that were just just mentioned, and people feeling a sense of safe apprehension when going forward with this in the community, because they're very easily accessible, particularly for adolescents. Thank you.
Yeah, I think it's an excellent question. I think really the only realistic way to mitigate the dangers of underground is to create a legitimate specialty of therapists who are trained and experienced in conducting psychedelic sessions, and for people to be able to make a intelligent choice. Obviously, people are free to choose underground, overground, or any therapist they want. However, they do need to understand risks and benefits. And I think talking about not only therapeutic potential and all the potential for cure of psychedelics, but also talking about what can go wrong in a balanced, sober, focused way is the only way to for people to be informed and make the informed choices.
Yeah, I would say that this is where the concept of harm reduction comes into play, which is sort of more of a community-based approach to educating people about psychedelics. So alongside our research group, we run a society called the Modzi Psychedelic Society, where we run integration groups, which is sort of a public-facing group that's confidential and safe. And whilst we don't condone that people use psychedelics in an illegal context, people will, and to turn your back on that would be not smart. So we have these spaces where people can come and ask the facilitators, who are people who work in our team, but they're not there in their professional capacity, but sort of if they're thinking about taking psychedelics, advice on how to do it as safely as possible, or they've just taken psychedelics and they want to talk about what happened in their experiences. So, not kind of ignoring that these things are happening, but approaching it with as much safety as possible.
Yes, the gentleman at the back there.
Hi there. Yeah.
Yeah.
Sorry. So at the start of the talk, they were talking about the amount of people who are going to be suffering in the next so many years. That's going to go to 2 billion. Will the use of psychedelics allow CBT therapies to be shortened down from a 6-week stint to maybe 2 weeks, allowing for more patients to be dealt with? Or is it just going to be in addition to additional therapies that we currently have?
I didn't fully understand the question.
Does it help compress CBT therapies and other therapies into shorter? Does it make other mental health?
I think it's the most interesting.
More efficient.
Yeah, I don't think it makes other treatments obsolete, but it will certainly, if the science holds in phase 3, I think that it will certainly make an impact on how other treatments and when other treatments are administered. So, as I said, it's also an interesting research tool. So I think it won't replace CBT. Not everyone wants to take psychedelics. Not everyone will take psychedelics. And we need the whole range of tools. But the learnings from this research will definitely inform the development of talk therapies, even if they're not related to psychedelics.
The man in the white there. Thank you.
Hi, I'm Joshua, and I'm the founder of DeSci World. I wonder if you guys have considered DeSci, or decentralized science, as a method to sort of improve research pathways and also sort of just the testing of it in general of these psychedelic products that you have. DeSci, decentralized science, is like DeFi, decentralized finance, but for science, and it's quite a new budding field, if you don't know.
Yeah, so there is a decentralized trial consortium at the ISCTM, International Society for Clinical Trial Methodology. I don't want to, geek out too in front of this audience, but as you said, it's quite a new tool. It can expedite the trials, but we are entering phase 3, and we won't be able to switch the methodologies for phase 3. You only have one shot at phase 3. But I think in the future, particularly for novel psychedelics, there might be a really good option for decentralized trials.
So I think that's pretty much all we have time for. Sorry, apologies. I just wanted to just quickly ask everyone if there's one thing that you want everyone here to come away from this talk with, what is it? Can you give us one key thing that everyone here should know? Is it psychedelics are coming?
I think we try all to balance like that. I think all three of us have a huge enthusiasm for the potential, yeah, but always make clear that for many reasons, yeah, it's sort of not where you go out now and say, oh my God, like I find a dealer on the street and I'm gonna do psychedelics because this panel was so optimistic on it. It is a medical drug, or they are medical therapeutics, and even beyond that, not just medical in terms of prescription, but you need to do it with a therapist together in a more holistic treatment, which, by the way, and then I come to two book recommendations, is how these therapeutics have been used for thousands of years in humanity. They were never party drugs like alcohol was. Like, if you can go in any society which is or has incorporated, is using psychedelics, from ayahuasca in South America to what the ancient Egyptian did, what the Greeks did at the Eleusinian Mysteries. They were actually, the sort of concept of therapy they were using is really resembling, I think, where we're going to end up. You have to do prep work. You have to do with a therapist, which was back then called a shaman or a priest. You have to do post-integration. It's highly regulated. You shouldn't do it more than once a year. So all of that, yeah, which we know or have known since thousands of years, is now going to be very scientifically recreated for sort of our modern world. So huge enthusiasm, but as a therapeutic sort of in a proper use. So, and because we just had 45 minutes, if you want to learn more, I think there are two books I always recommend. There is sort of the standard, I would say almost Bible or book for mental health and psychedelics. It's called How to Change Your Mind from Michael Pollan. And if you want to know more about the history and how they have already been used in humans and actually most likely inspired most of our religions, then it's The Immortality Key, written by Brian Murarescu. These would be the two books, so then you can take a deeper dive.
Fantastic. I was going to ask you too, but we're about to get kicked off the stage.
Okay.
I apologize. I apologize. But thank you so much for being here. It's been an incredible panel. We've learned about the scale of the mental health crisis. Those billion numbers being thrown around are just extraordinary. We've got a sense of kind of what's coming next, and a sort of, they don't like the word timeline, but a sense of when certain drugs and certain treatments might possibly become available in the near future. We've got a sense of what is actually happening in your mind, which I thought was totally fascinating, and like why this new paradigm makes sense for mental health. And I hope you all really enjoyed it and learnt a lot. And thank you so much for being here. Can we give a round of applause to our guests?